Hello and welcome to the topic Phobic disorders in the Psychiatry module. By the end of this session, you should be able to define phobic disorders, explain the pathophysiology and causes of phobic disorders, describe the clinical manifestations of phobic disorders, discuss the management approach to phobic disorders, and discuss the complications of phobic disorders. Let's get started. So, what does one mean by phobic disorders? A phobia is defined as an irrational fear that produces a conscious avoidance of the feared subject, activity, or situation. Collectively, phobic disorders are the most common forms of psychiatric illness, surpassing the rates of mood disorders and substance abuse. The affected person usually recognizes that the reaction is excessive. Severity can range from mild and unobtrusive to severe and can result in incapacity to work, travel, or interact with others. Specific phobic disorders involve persistent, unrealistic, intense anxiety about and fear of specific situations, circumstances, or objects. The anxiety caused by a phobic disorder can interfere with daily living because people avoid certain activities and situations. There are several biologic theories that are postulated for the pathogenesis of phobic disorders, most focusing on the dysregulation of endogenous biogenic amines. Sympathetic nervous system activation is common in phobic disorders, resulting in elevations in heart rate and blood pressure, as well as symptoms such as tremors, palpitations, sweating, dyspnea, dizziness, and paresthesias. Genetic factors seem to play a role in both social anxiety disorder and specific phobia. On the basis of family and twin studies, the risks for specific phobia and social anxiety disorder appear to be moderately heritable. Preliminary neuroimaging evidence indicates that while different patterns of brain activation might be associated with the different phobias, there is an overall increased activation in the prefrontal and orbitofrontal cortex, anterior cingulate cortex, insula, and amygdala in phobic patients exposed to phobia-related triggers compared with healthy controls. Psychological theories range from explaining anxiety as a displacement of an intra-psychic conflict to conditioning, paradigms, and cognitive behavior models. Many of these theories capture portions of the disorder. A behaviorist would see phobia as a learned, conditioned, response resulting from a past association with a situation that had negative emotional valence at the time of association. Even if no danger is posed in most social encounters, an avoidance response has been linked to these situations. Well, as for clinical manifestations, anxiety is the most common feature in phobic disorders. Other manifestations include sweating, palpitations, elevated blood pressure, elevated heart rate, dyspnea, dizziness, tremors, diarrhea, and paresthesia. Findings in a patient with phobic disorder may also include psychomotor agitation, such as restlessness, diaphoresis, which indicates an anxious mood, the ability to identify the reason for anxiety, as well as preserved insight. According to the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, with a 5th edition also known as DSM-5, phobic disorders are no longer a distinct group of anxiety disorders. Nonetheless, they may still constitute a useful conceptual category. The three diagnoses that may be thought of as belonging to this category are as follows. We have the social anxiety disorder, or known as social phobia. So here, a strong, persisting fear of an interpersonal situation in which embarrassment can occur. Specific phobia, which is an overwhelming, persisting fear of an object or situation. It differs from other anxiety disorders in that the fear and anxiety is induced by the presence of the phobic situation or object. And agoraphobia, the fear of being alone in public areas, particularly places from which a rapid exit would be difficult or help might not be available in the course of a panic attack or other embarrassing symptoms. Symptoms of phobic reactions may be psychological, such as an intense feeling of unease or foreboding, physical, such as crying, or gastrointestinal distress, or behavioral, which includes a wide variety of avoidance tactics. The specific DSM-5 criteria for social anxiety disorder or social phobia are as follows. Where there is marked fear or anxiety about one or more social situations in which the individual might be scrutinized by others, such as social interactions, being observed, and performing in front of others. The anxiety may occur in peer settings and not just during interactions with adults. The individuals fear acting in a way or showing anxiety symptoms that will be negatively evaluated. The social situation almost always provokes immediate fear or anxiety. The social situations are actively avoided or endured with intense fear or anxiety. The fear or anxiety is out of proportion to the actual threat posed by the social situation. The fear, anxiety, or avoidance persists typically for 6 months or longer. As for specific phobia, there is marked fear or anxiety about a specific object or situation. For example, flying, heights, animals, receiving an injection, or seeing blood. The phobic object or situation almost always provokes immediate fear or anxiety. The phobic object or situation is actively avoided or endured with intense fear or anxiety. And similar to social phobia, the fear, anxiety, and avoidance persist typically for 6 months or longer. Next would be agoraphobia. Here there's marked fear or anxiety about at least 2 of the following 5 situations, whereby there's using public transportation, fear of being in open spaces, fear of being in enclosed spaces, fear of standing in line or being in a crowd, and fear of being outside the home alone. The individual avoids these situations because thoughts that escape might be difficult or help unavailable if panic-like symptoms or other embarrassing symptoms occur. The agoraphobic situations almost always provokes immediate fear or anxiety. The agoraphobic situations are actively avoided, necessitate the presence of a companion, or are endured with intense fear or anxiety. So to begin with assessment, history taking is crucial from a patient with symptoms of a phobic disorder. The physician should inquire about other anxiety disorders, depression, suicidal ideation, substance-related disorders, caffeine intake, alcohol intake, difficulties in social situations, irrational and out of proportion fear, as well as intense anxiety reactions. Following that, for a patient with suspected phobic disorder, the mental status examination should assess the patient's appearance, behavior, ability to cooperate with the examination, level of activity, their speech, mood and affect, thought processes and content, insight, and judgment. To rule out anxiety secondary to medical conditions, the following tests might be useful, and these include thyroid function tests, fasting glucose, calcium levels, 24-hour urine for 5-hydroxyindoleacetic acid, drug screen, as well as cardiac enzyme tests. Imaging and functional studies can help exclude underlying seizure disorders, which these conditions may mimic anxiety, and a head computed tomography or CT or an MRI can be useful to exclude any central nervous system disorders. Treatment of phobic disorders usually consists of pharmacotherapy, psychotherapy, or some combination thereof. As a rule, a selected medication regimen should be continued for at least 6 to 12 months. If the symptoms have resolved and the patient is not experiencing excessive stress, the physician can gradually taper the patient off the medication. Psychotherapy usually helps make the transition away from medication more successful. Pharmacotherapy for social anxiety disorder may include paroxetine and sertraline, venlafaxine, escitalopram, citalopram, fluoxetine and fluoxamine, tricyclic antidepressants, beta blockers, and selected anticonvulsants such as gabapentin, pregabalin, valproic acid, topiramate, and tiagabine. So to summarize, phobic disorders can be characterized by an irrational fear. We have gone through the pathophysiology and causes and the specific different types of phobic disorders, which are social anxiety disorder, specific phobias, and agoraphobia. We have also gone through a quick process of history taking and mental status examination followed by important lab and imaging and functional studies that can be done to exclude an underlying medical problem or a concomitant substance or alcohol use. And finally, we have looked at the principles of management of phobic disorders, which is a combination of pharmacotherapy and psychotherapy. We have come to the end of this topic. Thank you.